You all can hear me, right? So this is July exam week day 3. Okay, day 3 file and the part 1. Okay, I don't think we can finish everything, but I'll try to cover many of topics from here. Okay, so yeah, the first question was like picture of tender red violet nodules in the shin. So what are those things? What are those red violet nodules on the shins? So what are those things? What do you think? Erythema nodosum. So, what are those erythema nodosum? So, what is happening? What is the mechanism of this erythema nodosum? What is the mechanism? What is mm-hmm. So, the problem in here, the fat tissue, like fat tissue inflammation, right? Fat tissue inflammation, or we call it paniculitis, right? We call it inflammation of subcutaneous fat, or we call it subseptal paniculitis, right? It's a painful, tender red nodules in the anterior shins, right? Can you see here? Like that. Okay, now tell me, what are the diseases associated with this erythema nodosum? Erythema nodosum. What are the diseases that associate with erythema nodosum? Okay, IBD. What else? You can type in the chat, and please keep your mic muted. Okay, what else? TB. Yes, you can see this erythema nodosum means streptococcal pharyngitis, right? So sarcoidosis, inflammatory bowel disease, it can be the Crohn disease or ulcerative colitis, right? Tuberculosis during pregnancy, and the people who are using in combined oral contraceptive pills also you can see, right? Otherwise, some uh, this can be associated with some drugs like sulfonamides, penicillins, like that. So, other than that, there can be fever, malaise, arthralgia, especially in the ankles, you can see as other non specific symptoms, right? So, please keep those in your mind. Okay, so in the exam, they have given a picture, and this is the picture that they have given in e medicine. So, we'll do this question because this question is very important. I will explain why. 28-year-old woman present to the GP clinic with 2 week history of painful red nodules on both shins. She reports feeling fatigue and has developed intermittent abdominal discomfort and diarrhea over the past month. She has no significant medical history and does not take any regular medications. On examination, she appears well with pulse rate of 72. Blood pressure 118 by 76. Respiratory rate is 14 and SpO2 98% on room air. The temperature is 37.1. There are 10 erythematous nodules on both shins. Can you see the both shins? And the abdominal examination revealed mild tenderness in the right lower quadrant. Chest X-ray is unremarkable. So now they're asking. The question is asking most likely the underlying cause, right? What do you think? Without seeing the answer, what do you think? What it can be the most underlined? Okay, I will give the options: Crohn's disease, ulcerative colitis, a streptococcal infection. So from these three, what do you think is the most important? Not most important. The underlying cause for this scenario, is it Crohn's or is it ulcerative colitis? Is it streptococcal infection? So what do you think? Yes, why do you think it's a Crohn? So why you are thinking it's Crohn, not ulcerative colitis? What is the reason? Okay, okay. What is the reason? Now tell me the reason. Okay, diarrhea can see in the ulcerative colitis as well. So what is the reason actually? Okay, so the reason is from IBD, the most common association with this erythema nodosum in Crohn disease. So that is the reason. Okay, here, erythema nodosum occurs in 4 to 15% of patients with Crohn's disease and can sometimes precede the onset of significant GI symptoms by weeks to months. Here, the most underlying cause of the patient presentation Crohn's disease, the combination of erythema nodosum, fatigue, and right lower quadrant abdominal pain with diarrhea is highly suggestive of Crohn's disease, right? So, and here the right lower quadrant pain, right? Yes, then ulcerative colitis. And can erythema nodosum, it's less common, 1 to 2% of cases than Crohn's disease. Additionally, the right sided abdominal pain more suggestive of Crohn's, right? So, we have two things you need to understand. The most common erythema nodosum associated with the Crohn's disease, and like you know how differentiates Crohn's from ulcerative colitis, right? Remember the most if they can give some scenario and ask in most common in IBD, in that case think about Crohn's disease. Okay, so that's the thing. And the ulcerative colitis usually in the left sided pain, right? Abdominal pain. Here they have given the right sided abdominal pain, right? Okay. So that is the one question. The other question that they have given is this one. A 35-year-old woman presented to the GP clinic with 4 weeks history of joint pain in her ankle and the elbow, associated with bilateral eye pain and redness. She reports 6 months history of abdominal pain with intermittent bloody diarrhea and weight loss of 8 kilograms. She has no significant medical history and take no regular medication. She works as office and smokes 5 cigarettes per day. On examination, appear unwell, pulse rate 100, BP 90 by 60, respiratory rate 18, SpO2 99%, and temperature 37.2. Abdomen is soft with tenderness in the right iliac fossa. There's a bilateral and symmetrical swelling in her ankle and elbow joint with restricted range of movement due to the pain. There are no overlying skin changes. Multiple erythematous tendon nodules are present over her shins bilaterally. So, which one of the following most likely causes joint pain? So, what do you think? What do you think, doctors? What do you think? Type in the chat. What about the doctors? Just try because these are emergency question. This question can be given in the exam. Okay, just not only knowing the erythema nodosum, the diseases. That's not enough. You need to know each disease how this presentation can present. Right. Here, the patient presented with the features highly suggestive of inflammatory bowel disease with the extraintestinal manifestation enteropathic arthritis occurs up to 30% of patients with IBD and typically affect the large joint in a symmetrical pattern seen in this case. The combination of chronic bloody diarrhea, weight loss, and constitutional symptoms strongly support an underlying diagnosis of IBD. Right? Okay. Right? So, yeah, can. Okay. So I hope you get the idea because just knowing what is erythema nodosum is not enough, okay? But it seems like this is the part Ricola has given the picture, tender red violet nodules on the shins, the diagnosis, and they have given the erythema nodosum. It can be erythema nodosum, but I don't. They can directly ask erythema nodosum, but in the more complicated way like this, also they can ask for that. You need to understand a different scenario with other symptoms, right? Other signs and symptoms, very important. Okay, so yeah. Next question. Picture of ring-shaped skin eruption, the diagnosis. Recall has given the answer as the granuloma annulare. So, what do you know about this granuloma annulare? What do you think about granuloma annulare? What is it? What is it? The granuloma annulare? Recently, I have not seen this question is coming in the repeating in the recalls, but in the July they have repeated. So tell me what is granuloma annulare. What is it? The definition, what is it? Okay, here this is from TJ. So granuloma annulare is a common inflammatory condition of unknown cause, typically present as an annular plaque ranging from the skin colors to shades of red or violet. And can you see? It's like a it's like a ring, right? Can you see? So the margin often feels beaded. Localized granuloma annulare can occur anywhere on the body, but most commonly on the back of the hand and top of the feet. Generalized granuloma annulare is more common in patients with diabetes, frequently misdiagnosed as tinea, right? Diagnosis It's confirmed with biopsy. The appearance of biopsy characteristic refer for the dermatological advice. So, what is the treatment option? What we can do for the granuloma annulare? So, what is the treatment option for the granuloma annulare? Treatment? Quickly tell me, doctors. Quickly. Otherwise, we can't cover more recalls. If we're not answering, how we should cover these recalls? Okay, here. So lesions usually clear spontaneously, right? These lesions usually clear spontaneously, but may persist for months or years, right? Most localized lesions resolve without treatment. It can be resolved spontaneously. However, the treatment is required when this condition present. So you need to remember these indications: persistent for months, is cosmetically unappealing or tender, interfere with normal functions, like example on finger. In that case, you can use this treatment like betamethasone dipropionate 0.05 ointment topically, or mometasone furoate ointment topical. So you can use topical steroid, right? With or without occlusive resin, you can use betamethasone or mometasone, right? So these are the management, but most of the cases is self-resolving. But if these indications present or patient requesting the treatment because of the cosmetically, like patient need to remove it, in that case you can think about this as topical steroid, right? Topical steroid. Okay, this is the question they have given in e-medicine. So because once you see the pictures during the recall has mentioned in the picture granuloma annular, the picture of erythema nodosum. Always, I'm especially telling this to the August doctors, always go and check the e-medicine question. The e-medicine question are the one they are repeating most of the time. Okay, because they are given, because emergency question always taken, that is the only question bank for the Australian Medical Council exam, and they are taking pictures from e-medicine. That is a proven theory. Okay, because I personally witnessed during my exam, and like most of doctors are giving the same picture came, same exact picture came, exact question came. Because of that, e-medicine is very important. Okay, so here, a 22-year-old woman, maybe this is the picture that they can give in the exam. A 22-year-old woman present to the GP clinic with concern about a rash on her hand that has been present for 3 months. She report no itching, no pain association with the rash. She has also noticed that she become overheated easily and has had several episodes of diarrhea recently. She has no significant medical history and no regular medication. She purchased new laundry detergent last week and had just moved to the new crowded rental apartment. On examination, she appeared well with vital signs within normal limit. Inspection of her hand revealed the multiple flesh colors, slightly erythematous papule around in a ring-like pattern on the dorsum of the both hand. The lesion are approximately 2 to 3 centimeter in diameter. They are asking which one of the following is most likely diagnosis. Okay, here. So the clinical presentation described the most consistent with granuloma annular. This condition typically present as asymptomatic, fresh-colored or slightly erythematous papules arranged in the ring-like or annular pattern after triggers such as trauma or bite. So dorsum of the hand is a common location that absence of symptoms such as nausea or pain is characteristic. It is more common in young people in older adults over 50 years age. It typically occurs on the female, and younger people tend to present as a smooth red papules over joints and hands or elbow. Adults more frequently demonstrate as multiple pink or skin colored small mileage papules over skin fold and may associate with HIV, diabetes, or malignancy. Localized granuloma annulare can associate with the autoimmune thyroiditis, which is hinted as in this case, right? And here again telling the it's often self-limiting and usually resolved without treatment within few months to 2 years. If treatment is desired, topical corticosteroid are typically the first line approach for the localized disease. So widespread or resistant cases, systemic treatment such as phototherapy or oral medications may be considered. A skin biopsy can confirm the diagnosis if there is uncertainty, right? but the clinical presentation is often sufficient for the diagnosis in typical cases. So keep this in your mind because they have given something extra from e-medicine than in TG, right? So these are the points you have to remember, right? Okay. So picture of ring-shaped lesion, skin eruption. Maybe this can be the granuloma annulare because the Ricola has given it as a granuloma annulare. Alright. Okay, this is the picture that they have given in e-medicine. So keep these things in your mind. Right? In your mind. Okay, so we'll move to the next question. This is the way you should do the recalls. Okay, this is the way you should do the recalls, theory, then question, then related e-medicine, if it is possible. Okay, tell me management of otitis externa. So tell me the management of otitis externa. Just quickly, just quickly tell what is the treatment. Are you sure? I'm just asking, are you sure? Are you sure? Sure, right? Okay. What about other doctors? Don't mind my background noise, doctors. Okay, which antibiotics you are using? Which antibiotics you are using? Yeah, can you see your mistake? Have you noticed your mistake? Yes, right. Yeah. Don't rush to answer any question. Don't rush to answer. Doctor, do you hear my background noise? Because my dogs are barking very loudly. Okay, that's good. That's good. Okay. Okay. So again, I'm telling, I don't know if the August doctors are here or not. Please keep these things in your mind. Do not rush to answer the question because you are getting 1 minute. I'm not telling like wait too much. Just read everything. Okay. Sometimes even though you know the answer, you are marking the wrong answer because you are rushing to mark use of steroid and you just so okay topical. You think it's okay, chlorone. Okay, this is the answer. Don't rush. Read it very carefully and answer it. Okay, we'll discuss about acute otitis externa. So, what are the features of acute otitis externa? What are the features of acute otitis externa? What are the features? What are the typical features? Tell me. Okay, okay. What else? What else? What else? There are a lot of. Okay. Ear pain can we see, right? Often. Mm-hmm. Pain when pulling pinna or pressing the tragus. This is very important, right? This is a very pathognomic feature for this otitis externa, right? Pain on tragus movement or pain on pulling pinna, right? Ear canal is swollen red. Ear discharge is common. Hearing may be reduced, right? Because okay, which part of the hearing system is affected by the otitis externa? Which part? Because we have conduction, the conductive so sensorineural pathway and conductive pathway. So what is the affecting path? Conductive pathway, right? Very important. So like when you are doing the recurse, think these things as well because sometimes they can ask about the complications as well. Okay. So here I will show from the TG what they have mentioned. Acute diffuse otitis externa, the swimmers is the same name. Okay, so diffuse otitis externa, the otitis externa or swimmers is the same name. Inflammation of the external ear canal that often follow the water exposure and maceration of the skin. It can usually be diagnosed with a clinical history and examination. Ear pain, pruritus, conductive hearing loss, swelling of the ear canal, tenderness of the ear canal or manipulation of the tragus or pinna, discharge or depressed, right? In more severe cases, there may be a regional lymphadenitis or cellulitis, so cellulitis of the pinna and adjacent skin, right? So, and it can be due to fungal infection as well. Okay, fungal infection as well, especially in the immunocompromised people. So remember, not only bacteria is goes in the, there can be fungal infection as well. The most recurrent fungal infection can be associated with the immunocompromised people, people who are having cancers, people who are taking HIV, having HIV, people who are in the cancer treatment, right? Like that. Oh, diabetes. Okay, here otoscopy important to distinguish between the acute diffuse otitis externa, otitis media, and ear problem. So in here, the tympanic membrane is normal or is problem with the tympanic membrane also. What do you think? What is something happened to tympanic membrane here? What about tympanic membrane? Can we see any tympanic membrane problem here? Its tympanic membrane is normal. There's nothing to do with tympanic. Where you can see the bulge in red tympanic membrane, erythematous bulge in tympanic membrane. In which case, otitis media, right? Yes. Please always try to differentiate those things. And otitis media also, you have otitis media with effusion, the glue ear. Okay, and you have suppurative otitis media, and you have acute otitis media. If you are like doing exam in August, please make sure you know these three things separately, because management can be changed, right? Because very important. Okay, especially the glue ear otitis media with effusion, that was a that was asked in June exam. Okay, June exam, very important, very important. Okay, yeah, very important. They all mention in the TG. Okay, then otoscopy is very important. Okay, to differentiate. In addition to infective cause, the non-infective causes of ear pain include trauma, foreign bodies, impaction of this sediment, and otologic neoplasm. Secondary causes include the referred dental pain, temporomandibular joint dysfunction, trigeminal neuralgia, head and neck cancer, or temporal arthritis, those things. Okay. Perichondritis may be secondary to otitis externa, right? Perichondritis, they have asked on, I think December they have asked. So there's a good question with a picture. Please go through that one as well, okay? Okay, so etiology of the acute otitis externa. So it's not December, November. Sorry, doctor. November in my exam. Yeah, November. Pseudomonas aeruginosa and Staphylococcus aureus are the most common causes of acute diffuse otitis externa. So, what is the most common causes? Pseudomonas, okay, and the fungal infection like automycosis occurs less frequently than bacterial infection, and usually followed by the prolonged of antimicrobial eardrops, Candida or Aspergillus species are most common fungal pathogens. Approach to management. Do not use oral antibiotic therapy for the acute diffuse otitis externa. Oral, okay? They are not telling don't use antibiotic. They are just telling don't use oral antibiotic, right? Okay, and you can use the oral analgesia because it's painful, right? Analgesia, paracetamol, and NSAID according to the severity. Okay, do not use oral antibiotic therapy for acute diffuse otitis externa. Use combination corticosteroid and antimicrobial ear drop. The choice depends on whether it's a fungal or bacterial, right? Here, then, okay, well, let's get the treatment. Okay, so antimicrobial ear drop for acute otitis externa when fungal infection is not suspected. Here, what you can use Cipro plus hydrocortisone, or you can use Cipro plus hydrocortisone, or Cipro with dexamethasone, right? Depending on the some in the images they have given dexa. Okay, so here, what else then? However, yeah. Okay, for patient with acute diffuse otitis externa, when fungal not suspected, use combination corticosteroid and antimicrobial ear drop. Avoid ear drop containing aminoglycoside like famotidine or neomycin. If the patient has a tympanostomy turbans situ or tympanic membrane that is known or suspected to be perforated, use ciprofloxacin containing ear drop if possible, because they are rarely cause inner ear damage, right? So you have to do the ear toileting with this Cipro plus Cipro plus some steroid. It can be hydrocortisone, like okay, or dexamethasone. Here, cyprohydrocortisone or dexamethasone, famotidine or gramacidine. So usually they are asking from Cipro with some topical steroid, right? If Cipro or aminoglycoside cannot be used, alternatively you can use flumetazone or cleoquinol, right? Here, advise patient to tilt their head to be opposite side after installing the eardrops, right? Okay, then then if it is otitis externa, when fungal infection is suspected, please remember that management because they can ask from this one as well. They can give a scenario with the immunocompromised patient with the recurrent these otitis externa, and they can ask the scenario like the fungal infection. In that case, you have to remember this thing. Sorry, triamcinolone plus neomycin plus gramcidine plus nystatin. Okay, here you have to give or flumetazone plus cleoquinol you can use, right? Okay, then preventing and management of the recurrent cases. Recurrent diffuse otitis externa is typically caused by dermatitis. It can be prevented by treating the dermatitis. If recurrence of infection occurs despite appropriate otitis externa, the treatment consider contact dermatitis, atopic dermatitis, seborrheic. You have to treat the dermatitis associate and keep the external ear canal free from water or also prevent recurrent diffuse otitis externa. To prevent water enter the external ear canal should be occluded with the earplugs or shower or bathing cap. To dry the ear canal after water exposure, use alcohol containing ear drop, acetic acid plus isopropyl alcohol ear drops, 4 to 6 drops instilled into the each ear after water exposure. Very important. Okay, I hope you get the idea about this one. There's a one question here. Okay, we'll do this question. Yeah, here. 45-year-old man present to the clinic with 3-day history of severe right-sided ear pain and associated with discharge. He has a previous similar episode of this resolved after using medication given into him by GP. He denies in history of hearing loss, tinnitus medications given to him by his GP. He denies in history of hearing loss, tinnitus, or vertigo. He is a swimmer and swims daily in a pool and then uses cotton swab to clean his ear regularly. He has no significant history or no allergies, no immune system disorders. They are excluding fungal. So examination, his right ear canal is erythematous and edematous with thick yellowish discharge because discharge can be common with externa. Right, the tympanic membrane is not visible due to the swelling, right? Okay, so after ear toilet, which one of the following would be the most appropriate management here? Cipro plus dexamethasone, right? Ear drops, right? The patient has present with the signs and symptoms of otitis externa. I will show a better picture, okay, for the otitis externa. In RCH, these pictures can given in given here otitis externa here. It's hard to even check the ear. Okay, this is how skin of external ear canal swollen and there can be thin pus. Because of that, it's very hard to doctor how we differentiate between that is another topic, doctor. That is another topic. So now I can't explain that topic. Okay, perichondritis and cellulitis. That was the question they have asked in November because you need to know perichondritis and how to differentiate. Because the cellulitis, you can remember the typical features, how it present, and you have to know how perichondritis seems like the features present. It's like do the investigation, then you will understand. Okay, because there's no time to explain that topic. I will do that in another day. Okay. So ingrown nail picture given the management. So ingrown nail picture given management. What do you think? Ingrown nail picture given the management. Ingrown nail. What you need to do? Tell me, doctors. Okay. So what is this difference between? So here what is the answer? So what is the difference between if initial? Mm-hmm. Okay. So what do you know about this ingrown nail or paranoia? What do you know about this disease? Okay, here. So let's discuss. So paranoia and ingrown toenail. So what is the difference between these two? What is the difference between these two? They are not same. They are not same. Tell me, doctors, what is the difference between paranoia and ingrown toenail? How to differentiate? Because like if you think you know the clearly the options, but you need to remember a lot of things for this one. Okay. What is the difference? Okay, so paranoia, that is just an infection or inflammation of the nail fold, right? So what is ingrown toenail or ingrown toenail? What is the nail edge grow into the lateral nail fold, right? This nail edge, this nail edge is grow into the lateral nail fold. I'll show. Can you see? Can you see? What is this? This is an ingrown toenail. Can you see? Right? So that is different, right? Two different things, right? Two different things, right? So paranoia, what is happening here? It's like just an infection, right? Infection, but no ingrown parts, right? No ingrown part. Here, so what are the causes of paranoia? Usually due to the Staphylococcus aureus, right? Or can be candida in chronic cases, but acute mostly due to the Staphylococcus aureus, right? So in ingrown toenail, it's due to improper nail trimming, right? Tight shoes or trauma, repetitive, not comfortable shoes, right? Those things. Okay. So where you can see the pain in paranoia is it's a very acute, diffuse pain around this nail fold, right? Nail fold, right, doctor? So, but in here, ingrown toenail pain at this lateral edge of the nail, the area where the ingrown part is there, right? Here in paranoia, the nail falls swollen, red, and tender. You can see in ingrown toenail, there's a local swelling present with this ingrown part, right? Ingrown part. Okay, then what else? Okay, what about the visible edge? Can visible edge in paranoia? Yes, paranoia, the nail edge is visible, but in this ingrown toenail, the affected area, nail edge is not visible, right? Okay, okay, that's all for the differentiation. Okay, now tell me the management. Now tell me the management. If it's a paranoia, when to use this initial management, when to use empirical antibiotic? Tell me, doctors. Okay, when to use empirical antibiotics? When to use empirical antibiotics? Okay, this is one from the TG. Oh, okay, I have not attached the TG, sorry. But we have discussed TG during the session. I forgot to attach. Because you need to know what are the types of antibiotics that they are using. Okay, here acute paranoia is an infection of the nail fold, usually caused by staphylococcus, and often occurs at the cuticle at the site of the hangnail or other injury. The area around the nail become painful, red, and swollen. Acute paranoia may aggravate the chronic paranoia. Right? For acute paranoia that does not respond to the local drainage or does not require drainage, take the swab and start empirical therapy, right? So what you can use declox or fluclox. So you can use people who have a non-severe hypersensitivity. Non-severe hypersensitivity, you can use cephalexin. If it is a immediate severe hypersensitivity, you can use clindamycin or trimethoprim sulfamethoxazole. Very important, okay? Then chronic paranoia. In that case, what you can use chronic paranoia is a painless traumatic nail dystrophy. It causes damage to the waterproof seal between the proximal, the posterior nail fold, and the nail plates. Example, pushing back the cuticles or removing the cuticles with the keratolytes. Once the seal is damaged, water and debris can enter under the proximal nail fold and cause inflammation. So cuticle loss is essential for the diagnosis. If the cuticle loss is intact, they consider other causes swelling of the proximal nail fold. Colonization with candida can occur, but antimicrobial treatment is not indicated because it rarely improves the condition. The basis of chronic paranoia treatment, corrected care, the cuticle and hand and topical corticosteroid. The correct care of the cuticle and the hand should contain until the cuticle regenerate, approximately 6 weeks. Advice is avoid pushing back the cuticles or manicuring nails, avoid picking at the cuticles, avoid inserting the object beneath the cuticle to remove the debris, and keep hand out of water and water cotton linen rubber gloves when washing or dishes or doing other wet work, and dry hand and nails after any wet or moist exposure. Use mild soap free wash and manage any underlying chronic dermatomes, right? So, what you can apply potential topical corticosteroids for chronic paranoia, betamethasone. You can use mometasone when the affect area is not inflamed and dry. Without exudate, apply white soft paraffin to protect the waterproof area, right? Like that. I hope you get the idea. This is the one that they have mentioned in TG. TG, right? Okay, so we were in here. So overall management, and here this is from the Terminate. This is from Terminate. Okay, you can type in there. Okay, we'll do this question. 30-year-old man present to the GP clinic with the 3 months history of recurrent pain, swelling, and redness around the right great toenail. He worked as a carpenter and enjoyed playing soccer on weekends. He's playing soccer on weekend and the carpenter. He has significant medical history and take no regular medications. Examination, he appears well with vital signs within normal limit. The lateral nail fold of his right great toe swollen, erythematous and tender to touch, with purulent discharge visible. The condition has not improved despite previous causes of oral antibiotic and proper foot hygiene. Okay, here. So they're asking which one of the most appropriate management of this condition. So now tell me the appropriate management. Okay, why here you go with wedge excision, wedge resection? What is the reason here you choose E as the answer? What is the reason that you choose E as the answer? The reason? Type in the chat. Type in the chat why you have choose E as the answer. So give me the key things from this one because those are the things that you need to improve, right? Okay, chronic history, not responding to the antibiotic, not improve with antibiotic. Okay, it's a recurrent case, right? Recurrent case here. The image and the clinical description are consistent with the chronic paranoia secondary to an ingrown toenail, right? The most appropriate management in this case is wedge excision of the toenail. This procedure involves the removing of the ingrown portion of the nail along with the associated nail matrix, which prevent recurrence. It is particularly indicated in the case of chronic paranoia that have not responded to the conservative management and seen in the patient who has had recurrent issue despite the previous treatment, right? Okay. Okay, so antibiotic when used may helpful in acute cases or as an adjunct to other treatment, but alone they are unlikely to resolve the chronic paranoia caused by ingrown toenail, right? Then it is worth nothing that the patient's occupation as a carpenter and the hobby of playing soccer contribute to the development and persistence of the ingrown toenail due to the repetitive trauma to the toe. Right? So, yeah, like that. Okay, so the general idea, this is the general idea I can, this is also the same. You can do in EMEDC question. Okay, so management, acute management without abscess, warm saline, water soak, analgesia, keep digit clean and dry, and you can consider antibiotic. Consider, but if it's a very mild case, you don't need to go with the antibiotic, just warm saline and water soaks and keep it dry. That is enough. Okay, if the acute pneumonia with bacterial infection and do the swab and antibiotic, you can use oral antibiotic, flucloxacin, decloxacin. Acute pneumonia with abscess, incision and drainage should be done, and you have to give antibiotic as well. The chronic pneumonia, avoid water irritants, topical corticosteroid, topical antifungal if candida suspected. Chronic pneumonia due to the recurrent ingrown toenail, and you can do the wedge resection. That is the definitive management, right? This is the overall idea about the paranoia management. So I'll move to the next question. Okay, here. A colleague with the diabetes prescribed medication for herself. What do you do? Advise her to see GP, inform supervisor, inform AFRA, prescribe for your colleague. What do you think? Okay. Uh, okay, another question. You have noticed a medical student with diabetes prescribe medication for herself. What you need to do? In that case, what you need to do? Report to supervisor, right? Why you should report in? Because medical students are not supposed to prescribe medication even for themselves, right? Yes, yes. So, and here the colleague, right? Colleague, diabetes prescription medication on herself. In that case, what you can do, advise her to see the GP. First, you can talk with the you can talk with this colleague, right? And you can ask like what is happening and what is going on, why you are not taking medication from your GP, and like you can recommend, like you can just give a friendly advice like you need to see the GP, right? Okay, you can encourage them to see their GP. Okay, next one. 45-year-old woman undergo routine elective surgery. Asked you not to include her history of self-harm into the medical record. What you need to do? What you should do? What you need to do, doctors? Yes. Okay, here. Doctor have professional and legal duty to maintain an accurate and complete medical records, right? That is their duty. The history of self-harm is clinically relevant, particularly before surgery, and should not be omitted simply because the patient requests it, right? You need to write down everything like a proper details, right? The accurate details, right? You can't remove anything if the patient asks to do, like you can't do that, right? But you can do other thing. You can explain her medical records are confidential, only the access is having the healthcare professional involved in the case, and reassure that information record ensure with the safe medical care, right? So in that case, reassure her that the medical records are confidential. It should be the answer, right? Next one. Which study designed best to determine whether the number of dysplastic nerve is associated with the incidence of melanoma? Okay, they're asking what incidence. Okay, if you don't know anything about how to do it, what you need to do is, okay, if you don't know anything about any of these incidents, but I'm always telling you to remember some keywords. If they ask incidents, what to choose? If they ask incidents, what to choose? cohort, right? If there are incidents, you have to always choose cohort, right? Okay, let's see what is happening. Yes. So if there are some drug efficacy, what to choose? Efficacy of some drug. You don't know anything about studies, but you know the keywords. Efficacy of drug. RCT, right? Like that. So these are very important and you need to remember all of these things before you exam. But don't forget to read it, okay? Don't forget to read it. Okay, 1 minute. Then, okay, where you can check the prevalence. Prevalence, sorry, where you can see the prevalence check. Thank you so much, doctors. Yeah, if other doctors have not watched that my stat video, please go and check it. Okay, I have explained everything in a very simplest way. It's a cross section, right? So keywords. Prevalence cross sectional. If you don't know anything, just remember the word prevalence cross sectional. Even when I was preparing, I also don't like the stats. But I didn't like even though I don't like, I just went through some topics. Okay, I just fully ignore them. I just not fully ignore them. Okay, I just went through some topics, but in that time, I was not trying to understand it properly. But once I'm doing the sessions, I explained everything for you very clearly. Okay, everything in my YouTube channel, and you can go and check it, like everything. I didn't know. There is a YouTube video. I didn't know, but have you done exam in November? There was two question in the stat. I did exam in November. Okay, you can't tell that. Okay, okay. And the funny fact is, in this year they are giving us the different concept. In the July exam, they have given antigenic drift and antigenic shift topic, right? Then in June, I think June or September, they have started the serotype. Sorry, 1 minute. Just 1 minute. Sorry for that. I'm not feeling well nowadays. Yeah, then they have given the serotype conversion or serotype replacement, serotypes change, like a different topics. But they have not forget to give the usual that chart sensitivity versus specificity chart. They have not forget to add. I have seen recently each month they have asking from what is 100% specificity, what is 100% sensitivity. They have given that chart as well, and now they are adding a new topics as well. For August. Okay, let's see. Please remind me, okay? I have a lot of things. Sometimes I forget it because a lot of topics came on in this year. A lot topic. A lot topic. I think from April, May, we got a lot of topics. Antigenic drift, shift, because they were not the answers in the questions in July also, but you need to know what is drift and shift as well. Okay, those things. Okay. Enough of gossips, right? We'll move back to our case. Yeah, every mark makes sense because I know many doctors who fail by 1 mark, just 1 mark. Okay, just 1 mark. No, can't tell that this year, but like last month, and it's depend doctor. Some like stat question, not only stat question, because this year the hardest exam was only the March exam. Other exams are doable, but they have changed the pattern. They have yeah, can't tell like hard anyway. MC is hard, doctor. Anyway, MC is hard. Okay, okay. Enough of those gossips. We'll discuss about AMC. The real face of AMC, end of the session. Okay, here. The question asks whether the number of dysplastic nerve with exposure is associated with the incidence of melanoma with the outcome, right? The core study is the best design because it starts with the people with and without exposure. August revision classes are starting after August exam week, doctor. After August exam week, because like we need recalls, right? First, yeah. So at the nowadays, I'm doing the July recall classes ongoing because some days I couldn't do because of some problems. Yeah. Okay, the people with and without exposure, follow them over the time, measure the incidence of melanoma, then can calculate the relative risk. So it's a cohort study, right? Okay, next one. Which findings suggest the fracture of the orbital floor? This classes, let's see, because most doctors are requesting me to do the recall, then they can cover a multiple topics in different areas. That's what I have decided to do, like more recall classes. Okay, why limited range of eye movement? What is the muscle or innervation is affecting if it is the orbital floor fracture? Yes. What if it is orbital floor fractures? What is the problematic area? What is the area that damage can happen? What is the area? Yes. So orbital fracture or orbital floor fracture or blowout fracture commonly cause entrapment of the inferior rectus muscle resulting in limited upward gaze, restricted eye movement, right? Limited but the upward gaze, right? Because it affects inferior rectus muscle, then diplopia, especially on looking up, infraorbital numbness and endophthalmos. Those things can be happen. Okay, so in that case, limited range of movement. Next one, picture of drainage of the parotid gland with the syringe. Which condition require this procedure? Which condition require this procedure? So they're asking about the parotid abscess, right? So which one need drainage? So where is the pus? You need to drain it, right? So where is the pus? Pus in the abscess. So parotid abscess or suppurative parotitis, right? Parotitis with abscess, right, doctors? So what is the management of parotitis with abscess? What is the management? It's just IND only. Okay, is that IND only? Which antibiotics? Is oral antibiotics? IV, right? Once you answer in a question, you need to drainage with IV antibodies. That is the complete answer because drainage can be percutaneous drainage and IND. We have two options, right? We have two options, but for the most of the cases, we are using IND because percutaneous drainage can cause the recurrence, right? Cause recurrence. The recurrence is high in percutaneous drainage, right? Okay, if it is just parotitis, if it is just parotitis, what you need to do, the treatment, the management, just parotitis. Okay, okay, I'll explain. No, no, IV antibiotics, doctors. IV. Parotitis inflammation of the parotid gland. You all know that is factors elderly or deliberated patient, dehydration, recent hospitalization, immunosuppression, those things. So, clinical features painful preauricular swelling, fever and systemic symptoms, erythema and warmth over the parotid area, pus expressed from the extension duct or parotid duct. Trismus, difficulty chewing or opening the mouth, right? So these are the red flags that suggest the parotid abscess because parotid abscess is a kind of severe case because that can arrest the respiration, right? That can affect the respiration, right? So fluctuant tender mass. So once you see the fluctuant tender mass, always think about some abscess, fluctuant tender mass, right? In the severe pain, trismus with the airway symptoms. Airway symptoms are very important. Trismus very important. Inability to lie flat or swallow, toxic or septic appearance, right? Investigation clinically diagnosed in the most cases, ultrasound if abscess suspected, CT and head neck only if the diagnosis of uncertain or deep neck infection suspected. Culture of the expressed past if not improving in parotitis. Okay, so we'll do this question. 70, this question, the exact question came on March exam. Okay, I can tell you this image. The one of doctors in my exam week class, she told me this exact question came on um, March exam, and we have discussed this question multiple times on our recall classes because this topic is repeating. Okay, so that's why the image is most important. Okay, so 76-year-old woman from the residential care home present to the emergency department with 1 week history of painful swelling in front of her left ear. A nurse indicate that she has refused oral intake for past 2 days and she has a medical history of congestive cardiac failure and hypertension. Her medication includes furosemide, recently increased ramipril and spironolactone. She has no known allergies. Examination appear unwell. Pulse rate is 110. BP 135 by 85, respiratory rate 22, SpO2 96, the temperature 38.2. The swelling is warm to touch, tender and fluctuant. She is unable to open her mouth more than 2 centimeter and difficulty breathing while lying flat here. So, which one of the following is most appropriate management? Warm compression, IV flucloxer, ultrasound guided aspiration, parotid duct decompression, incision, and drainage. Okay, what about other doctors? Why you asking me? Why you asking, giving a question mark? You are the one doing exam, not me. I have already done my exam. Okay, just try to mark answer from here. Answer from here. I just explained, right? What is the difference? In here, patient is okay. In here, patient is having what? Patient is having a toxic appearance. Patient can't breathe, right? Unable to open her mouth. Trismus present. Here, difficulty breathing. So in this case, what do you need? You need urgent decompression. This is the abscess, right? You need urgent decompression. Why the patient is deteriorating, difficulty breathing. She can't breathe while lying flat, right? So very important. What you need to do? I and D, right? Patient presented with the parotid abscess likely participated by the dehydration from increased diuretic therapy. The clinical feature is supporting this diagnosis, including location of the swelling, fever, trismus, and fluctuant endemas. The patient's systemic symptoms, fever, tachycardia, functional impairment, inability to eat, difficulty in breathing, when supine indicate the severe infection requiring urgent intervention, given difficulty in lying down and difficulty opening the mouth. Sorry, sorry. Open mouth and reduce oral intake, incision and drainage is the most appropriate option due to the urgency of presentation. This provides immediate decompression, relieve the pain, and allows for bacterial culture to guide the antibiotic therapy. So worm compression. Okay, I don't know. Here, why not ultrasound? May be useful for temporary symptom relief, but without appropriate washout, there is a chance of recurrence, right? That is the problem with the ultrasound guided aspiration. I just explained earlier, right? I just explained earlier why IND is better than ultrasound guided aspiration, right? And here, in given severity in the presentation, IV flucloxacin would not work rapidly enough to reduce the symptoms. In patient with mild presentation, intravenous antibiotic may be considered as a conservative management prior to incision and drainage. Parotid abscess, once relatively common post-operative complication, is now rare. It tend to occur in deliberate patients who have become dehydrated and have reduced saliva flow. And parotid duct obstruction secondary to the stone is another cause of the abscess formation. When draining the abscess, care must be taken to avoid the damage to the facial nerve. Here, this is the one they are telling, where there is pus, they are evacuated. Okay. Okay. Okay, now tell me the answer for this one. As a 35-year-old man present to the GP clinic with a 2-day history of pain over the both preauricular region, and he has been home for past 2 weeks recovering from a flare up. His non-Crohn history, which had required 2 weeks hospital admission and commenced of corticosteroid. He also has a medical history of depression and currently attempting to the quit cigarette smoking. His regular medication includes azathioprine, sertraline for depression, and nicotine replacement therapy. On examination, he appears unwell. Pulse rate is 100. Blood pressure is 130/80. Respiratory rate 18. SpO2 98. Temperature 38.2. There is a warmth and tenderness on palpation preauricular region, pus expressed from the parotid duct, and there is no evidence of dental abscess. Which are of the following most appropriate? Now tell me the answer, then I can decide you have understood or not this correctly. Are you sure? I'm asking, are you sure? Okay, anyway, it's a parotitis present, it's unwell, right? Yeah, it's anyway unwell, right? If there's infection going on, not a toxic appearance. Temperature present, fever present, warm and tenderness on palpation in preauricular region. Pus is expressed from the parotid duct. Okay. You think? What is this? This is just a classic presentation of parotitis. Parotitis, bacterial parotitis include bilateral preauricular pain, fever expressed from the pus from the parotid duct or Stenson drug, recent hospitalization, immunosuppression due to Crohn's disease, and steroid treatment, significant risk factor. So IV antibiotics is the mainstay of treatment, right? Right. Why you have choose surgical washout? Is there any abscess? Is there any difficulty breathing? Here, where your surgical washout not typical the first line, if only consider there is no response to a full course of antibiotic. In most cases, antibiotic therapy is sufficient. Abscess are present. Needle aspiration under ultrasound guidance may be performed before considering more invasive surgical interventions, right? Okay. So the summary of management, uncomplicated acute bacterial parotitis, mainstay IV antibiotics, IV flocloxacin with supportive care. Thyroid abscess definitive management is the drainage with antibiotic, ultrasound guide aspiration, no incision and drainage, and IV antibiotics, right? So yeah, here the simple management. Okay. Okay, next one. Education for 13-year-old girl who has already received sex education. Most relevant topic, alcohol and substance abuse. What do you think? What do you think? Okay, if I'm giving a set of answer, alcohol and substance abuse, sun protection, then acne. What you should choose? Sun protection, acne, alcohol. Why sun protection? If sun protection is not there, what you should choose? If sun protection not there, what you should choose? Okay, don't read this one. Okay, this is very important thing. Okay, earlier, what is the okay? Read this part very carefully. In In RCH, Australia has one of the highest rates of the skin cancer in the world. More than two in three Australians will get the skin cancer in their lifetime. Thankfully, skin cancer is one of most preventable cause, one of most preventable cancer. Teaching your child to protect themselves from the sun at younger age will set them up with a good habit for the future. Also important to practice good sun protection behavior. Young people learn by watching their parents and caregivers. If you are the sun safe, your child will be more likely to copy and protect them from the suns too. Okay, so here if they have given like school-based health education session, this is the April record. 13-year-old girl, the school already has sex education. They are in here sun protection by sun protection. They think logically because in Australia here, more than two in three Australians. One of the most commonest cancer in Australia is the melanoma. Melanoma, the skin cancers, very important, and most of the skin cancers are due to what? Due to sunlight, and the skin cancers are the one it's most preventable, right? Most preventable and higher prevalence in Australia. In that case, the better option is if you can teach your children in the younger age to practice the sun protection, the sun safety methods like using sunscreen, right, and those kind of sun protection methods that will help them to reduce the cancer in their future life, right? Skin cancer in their future life. So that is the one of most important thing you should consider. Okay, you should consider because of that here. Other than sexual education, you can give more priority for the sun safety. And this is the one question. Another question they have asked in here. They have asked in May 13-year-old girl health education what advice? Self skin check, acne advice, alcohol advice, pap smear, diabetes here. Okay, why now you can ask me why not self skin check? So sun protection and self skin check is two different things, right? Two different things. So sun protection and self skin check is two different things. Self skin mean you are checking for these this nervy, right? These moles, those things, right? That usually we are giving priority in people who have in the family history of melanoma or those skin cancers. But like overall for everyone, you should give the proper idea about the sun protection. Sun protection to prevent the skin cancer risk in their future and their day-to-day life by protecting from the sunlight, right? Okay, so here the sun protection is not given in that case. There is our RSCGP has mentioned something here. Okay, here advise children and people advise. Okay, there's a no strain protocol. Just advise children and people who are aged less than 18 years not to drink alcohol to reduce the risk of injury and other harm to health. So they have mentioned less than 18 years old people, you need to advise them about alcohol, right? Alcohol, very important because in Australia, the most adults and are more risk for this alcohol abuse, right? Alcohol abuse and the other substance abuse as well. But main thing is alcohol, okay? Alcohol, because of that if the sun protection is not given you can think about going with the alcohol. And I can show you this is a picture. This okay, you all know what we have used in earlier Amadex and Implax. Now we are not using, don't even think about using the Amadex or Implax, okay? But you know in previously we didn't have any options before coming to the before coming with this e-medicine. With the only option we have is Amadex and Implex. So they are also taking recalls and they are making these questions, right? Questions. And there's a one question in those Amadex. The earlier it's a earlier repeated question in the history of AMC. This one, okay? As a JP assigned to give the lecture to the girl high school. At school, you are told that girl you will be taking today, her 13-year-old, and that sex education topic has already covered with by another doctor. The which one of the following topic most important? Consider to cover it's a sunscreening. because age-related healthcare in the children and the young people from yeah, promotion of sunscreen to use the prevent screen damage and skin cancers in the future. The only option should be covered for this age group. It's all question from Amadeus, but don't use Amadeus again. But I have attached this question because this can be the e-medicine question bank question, because you all know not sorry, not e-medicine, the AMC is like a question bank, right? AMC is a question bank. There's a question pool, right? Pool, and from this pool you are getting the question. It's a computer adaptive testing. How, like, the you are getting the question, the way you answer in the question, right? The way you answer the question. They started with the medium level of question. The medium level is the question standard, the medium level, because we have harder question and we have easy question and we have the medium level. They're starting with the medium level and they're assessing your knowledge. Are you marking it correct, or you are marking it wrong? So you are again they are giving the same, like a little bit easier but same medium standard question. Again you are marking it wrong, then they are trying to give okay, because that is computer adaptive exam. This is the adaption. Okay, this is the adaption. If you mark that answer also wrong, then the computer is thinking okay, you need to give some little bit lower question means that the easier question, then you mark it correctly. And like they are continuing, and then again up their level. But like if you feel like, because most doctors are telling after the exam was super easy, but after the getting their result, they will most of not the most, like some doctors got the result without like 1 mark, without 2 marks, like 248, 59. Maybe like they feel like they have done easy question, but the amount of the score amount is very little, not very little for compare with the medium question and the higher standard question. Because if you are doing a harder question more, you will get the higher mark, right? Then you can jump to the 250 range easily, right? 250 range easily, like that. Okay, so that is something like this is something the stat side of the computer adaptive test. Okay. Okay, that is some extra thing. So remember, if they have asked about the directly sun safety is there, so go with that. If it is not, go with alcohol. Okay, so those two are the one that we can find the some preferences, some not or the CGPs like a preventative measures, right? Preventative book for to prevent from future cancers or like everything, and alcoholism, everything. So you have to follow those things. Okay. And I was telling the all recall is this the 13-year-old girl, the sexual education has done what is next, because the all Amadex has mentioned it as a sun protection, and we like it's a logically correct. Okay, I hope you get the idea. This is my recall file, doctor. This is I can't share this file. Okay, because this is my paid class file. I'm just explaining from it. Okay. So next one. Okay, next question is NIPT is normal but normal translucency is increased. What is the next step? What is the next step? What do you think? Okay. Wait a minute. I'll show some very important thing. I think we have discussed in day two. 1 minute. 1 minute. I want to explain about the prenatal screening things. 1 minute. Okay. I have to find out from which file. Just wait a minute. Because this is the second or third time we are getting question in July recall revision. So in earlier file I have attached it. The prenatal screening. Ah, yeah, here. Okay, this is day 2 file. First of all, we'll discuss about the prenatal testing. So we have prenatal testing, two types of prenatal testing. So what are those two types of prenatal testing? What are the two types of prenatal testing? We have screening test and we have diagnostic test, right? A screening and diagnostic. We have what? A screening test and what is other? The diagnostic testing, right? So what are those screening testing? Okay, screening testing. We are using this screening test to determine the risk only. Okay, determine the risk, not the diagnostic. Okay, determine 1 minute. Sorry. Okay, sorry for that. Sorry. 1 minute. Okay. So there's another question. Okay, here. So we have what? We have first trimester screening, right? We have combined first trimester test. So what are those combined? We have Nuhal transfluency, and just remember we are doing Papa, okay? Papa test, like that. Because the PA, this test, and free beta SCG, right? Then detect the risk of trisomy 21, trisomy 18, and trisomy 13. Then we have NIPT, the most sensitive one, NIPT, from 10 weeks, because you need to know from which week you should do. From 10 week onward, right? High sensitive for the trisomies, right? Not for everything, just for trisomies. A screening test only. Positive result need confirmation with CVSO amniocentesis. Very important, okay? So we have second trimester screening. AF alpha beta proteins or beta CGS, striol inhibin, those tests, quadruple test. Then morphology scan, usually 18 to 22 weeks. We are doing the detect structural fetal abnormalities. So keep in mind the most important two things is diagnostic test. These provide the definitive chromosomal diagnosis. Okay. So chronic villus sampling is we are doing in 11 to 13 weeks, right? 11 to 13 weeks. Placental tissue sample, earlier diagnosis possible. Significant miscarriage risk higher here. Okay. So indication in high risk prenatal result, previous chromosomal abnormalities, family genetic disease, amniocentesis from 15 week onwards, amniotic fluid sample, karyotyping, genetic testing you are doing. Okay. NIPT from 10 week, CVS from 11 to 13 weeks, and amniocentesis from 15 weeks, and morphology scan from 18 to 22 weeks, right? Here, and yeah, this is chart they have given in RSCGP. You can type prenatal screening RSCGP, then you can find a booklet or something in there. You can find this one. Okay, everything is mentioned here. Everything is mentioned here, when to do and everything. Here, CVS 11 to 13, amniocentesis from 15 weeks. Okay. Yeah, and NIPT from 10 weeks, like that. First trimester, the combined first trimester screening. So here, no transfer, the same thing. Okay, Papa and those things. From 11 to 13. And the second trimester screening, the quadruple test from 15 to 20 weeks. Okay, very important. And yeah, okay, so now you know those parts. So where was okay here. Okay, here NIPT normal, but Nuhal transplants is increased. So what are the things that that can, okay, if the Nuhal transplants increase mean what? What is the problem? What is the problem with increase of null transfluency? It can be associated with what? It can be associated with what, doctors? Increased null transfluency can be associated with what? Okay. Okay, here. Null transfluency. More than, okay, this is the question they have given in day 2, more than 6 millimeter is strongly associated with what? Chromosomal abnormalities like trisomy 21, 18, 13, or Turner syndrome. It has association with the chromosomal abnormalities as well as it has a structural abnormality. So don't think it's only associated with the chromosomal problem. It has a structural abnormalities as well. Okay, especially congenital heart disease. Okay, I'll show the other features here. It can be associated with the cardiac defect, various genetic syndromes, and delayed neurodevelopment. Neural tube development problems can be associated. Okay, here. Now that is the other thing. Okay, here you see NIPT normal, but no health transparency indicate. Does that mean you are directly go with the ultrasound, or do you need to confirm something before that? Because NIPT is only just a screening test. Do we need to confirm? Do we need to do confirmatory test? Then why you have choose series ultrasound in tertiary care? Why? Why you are not giving the proper answer? Because this is the recall answer. This is the recalls. So if the answer is not here, you need to give the proper answer. Doing recalls mean not marking any answer given. So don't do even in the exam week, especially the exam week, don't mark answers if the answer is not given in there. Okay, not given in there. If the answer is not there, don't just mark, because if you are marking the answer during the exam week, like not a proper the exact answer, in that case, what you in that answer is like store in your mind, like it's like a I don't know how in your like deep conscious it can go inside. Once you are doing the exam in front of your computer, you will suddenly pop up in your mind, oh, that was the answer mark, so yeah, I think that is the answer, something like you are not even reading the, yeah. Yeah, reading the question properly, you think that is the same question, and okay, we have marked in here that one. So because of that, okay, that should be the answer. You are not even thinking. You know the theory, you know properly how to solve that recall, but your mind is always thinking, okay, I can quickly mark and move to the next question. That is the way most doctors are failing this exam. They are memorizing the answers from these recalls. The recalls are just recalls, right? You need to cover whole topic, not just the answers, right? Yes. Yeah, brain tricks and AMC tricks from other side, and they will fail, and you have to pay again, and uh, you can reach you can reach Australian government again and again by paying the, right. It's not a cheap exam, it's expensive exam, especially for the Asian countries, right? Yeah, it's better you can, yeah, you're paying for development of Australia, right? Yeah, yeah. Just for fun, okay? Yeah, okay, here. What you need next, you need to look for the confirmatory test, because the NIPT only very specific for those trisomies, right? Not for all the chromosomal abnormalities, because the increased null translucency can be two things. It can be due to chromosomal abnormalities, it can be due to structure. Then first you can do the confirmatory test, and then you can refer this patient for the tertiary hospital to do the series of ultrasound, because this can be associated with what, associated with this structural problem as well. I'll show the question they have given in where in the, yeah, I think this is in June exam. This is in June exam. Okay, wait. Dr. Sithara. Okay. Okay, this is the question they have given in June. Okay, pregnant lady, CVS done 46 HY, ultrasound done at 12 weeks show the increased nuchal transmission. They have already confirmed the chromosomes are normal 46 XY, and still and there's a increased nuchal transference. In that case, you can go with tertiary center because they have already ruled out confirmatory testing right here. Think very carefully. You have to compare all the recalls if you like, if you have it. But remember the order. Remember the order. Okay, order. If it is screening test, you need to go with the diagnostic testing. Then you have to think about why. What is the other problem with increased neural transfluency? That is structural problem. In that case, you need to do the ultrasound as well. Okay, ultrasound as well. Yeah, that was it. Okay. Yeah, better to look for the confirmatory test here. This is from the RSCGP again. That book I told you about the prenatal screening here. NIPD does not screen for all chromosomal aneuploidies, single gene disorders, or neural tube defects. So high risk results should be confirmed through the diagnostic testing, right? Confirmed to the diagnostic testing. Very important. Okay. Okay, next question. 15-week pregnant woman with increased nodal transference 6 millimeter despite NIPT seek confirmation. So 15-week, they are directly given what you can do. You can go with the amniocentesis and confirm it, right? Then you can go with the ultrasound in tertiary hospital. Next one, karyotype 45XY abnormal result after prenatal sampling. Next step, what you need to do? Because this is 45XY, right? Abnormal, right? You need to refer for the genetic counseling, right? Because they already confirmed the karyotyping, right? They already done the confirmatory testing, right? 45XY find out after prenatal sampling. So there is a problem with, because it should be 46XY. So 45XY, there should be some problem with genetic. So better to refer them for the genetic counseling, right? Okay. Okay, here. This is the April recall, Dr. April. Okay, April recall here. Again, I have attached it. Okay, everything is here. I have attached it again. Next one. Okay, so 1 minute. Okay, you can read the question. Patient with hematemesis and perforated gastritis. Uh, perforated gastritis. Okay, taking apixaban. What I think perforated gastric ulcer. Taking apixaban. What do you do? Yes, okay, now tell me what are the agent that you can use to reverse the apixaban effect of the apixaban what you can use. And we have two things, right? We have two things, very important. This patient has a major GI bleeding, right? Hematemesis with perforated gastric ulcer, which is a life-threatening emergency. Patient need emergency care, right? So the management include stop apixaban immediately, right? Otherwise, this can be the bleeding can be worse, right? And you need to reverse the apixaban, administer reversal agent if the bleeding life threatening or requires emergency surgery. Andexanate alpha is a specific reversal agent for apixaban, but most of the time we can't see this andexanate alpha. But you can use as alternative. You can use PCC. PCC recommended in Australian practice. Okay, fun available. You can go with PCC. I have not seen about andexanate alpha, but I have seen in the question using PCC. Right? Yeah, that's okay. Here, same thing. Female to male transgender person, which one of the following changes will be reversible? What do you think, doctors? This is the all recall, right? This is the all recall. April also it came. A transgender male has started on testosterone therapy. Here the voice dependent with the this is from RSCGP. Voice dependent with the testosterone is usually irreversible. Some patients report vocal fatigue with the testosterone, which is tiring and hoarseness of the voice that worsens throughout the day. This is particularly relevant in the occupations where voice projection is required and speech pathology referral may be considered. So that voice, right? Voice depending. Yeah. Okay, 10-week pregnant patient, hepatitis C positive. What is the most appropriate management? Hepatitis C, what you need to do? Okay, can we give antiviral during the pregnancy for hepatitis C? Can we give antiviral? Those DAA contraindicate. Okay. Can we give antiviral if the patient is having hepatitis B during the pregnancy? Hepatitis B, can we give antiviral? What do you think, doctors? A4. Type in the chat. Okay. Okay, what is the name of the drug that you can give during the pregnancy in hepatitis B? Don't confuse these two things. What is the drug? What is the preferred drug for hepatitis B during the pregnancy? Name of the drug? What is the name of the drug? Tenofovir, right? Tenofovir. Is there only one doctor who answering? What happened to other doctors? Okay, so monitor non-specific antiviral treatment during the pregnancy. Very important. Okay, so I'll tell what you need to do here. Data about the safety of DAA, direct acting antiviral drug in pregnancy are limited. Don't confuse. Don't think we are using the same treatment, same antiviral for the hepatitis B and C. Okay, there are different regimen. Okay, and here B we can use tenofovir. 1 minute. And the indication of tenofovir in hepatitis B during the pregnancy also very different. Okay, you have to, that is something different. Okay, in hepatitis B you have to consider three stages, right? If it is patient is already on the treatment or patient is having the chronic hepatitis, like there are different indications because that also have asked in has asked in this July exam. So that's what please go through the hepatitis B during the pregnancy as well. Okay, everything is very clearly mentioned in TG. Okay, here DAA contraindicated, and here this is from the SA Health. Okay, antenatal screening, hepatitis C antibody is offered to all pregnant women at their first antenatal appointment. You have to check first, right? And here there are no data regarding of the risk of vertical transmission during the procedures like amniocentesis, so CVS. But you need to make sure if the patient is having higher viral load, you have to consider about the CVS and amniocentesis as well. Because if the patient is having higher viral load, that can be this CVS sampling or the cephalic version, external cephalic version or amniocentesis can also be risk for the transmission here. However, in the presence of a high level of viremia, the vertical transmission risk may be higher. Okay. And here, if it is HCV antibody positive and RNA PCR negative, what does that mean? Antibody positive, PCR negative. So in hepatitis C, why we are using PCR? PCR to what? To confirm what? The PCR in HCV. Hepatitis C, what is the indication of PCR? The general knowledge, okay, this general details that I'm asking. Okay, to confirm the current infection, right? The active infection, the current infection. Because from the serology, we can't tell is it a current infection or the past infection. So you need to do the PCR to confirm it. This also all recall. Okay, this also all recall. So if you're familiar with recalls, you are very understandable about these things, okay? Because these are just general thing for AMC, not AMC, but specifically mentioned in AMC questions, okay? So very important. So here, HCV antibody positive indicate exposure to the virus. RNA negative mean may represent either false positive antibody or past cleared infection, past successful treatment or lower level of viremia below assay detection level. Maternal follow-up required in 6 to 12 months to check the sustained clearance. Explained to the woman that a single negative maternal RNA test does not exclude all risk and advised to consider anti-HCV test on infant at 18 months of age. HCV antibiotics and RNA PCR positive. The PCR positive, wherever possible, refer to the infectious disease or hepatologist for the counseling should be occur before delivery. The medical officer should use clear language. You have hepatitis C because you have confirmed with the PCR, right? Explain, explain that hepatitis C is a notifiable disease. Advise testing for hepatitis B and HIV if not already tested, right? Very important. It's the only thing you can do is monitor. And education. Verbal and written consent information should be given about cause of the illness, preventing transmission, need for the further monitoring, and issue around the disclosure and stigmatization. Investigation. You can take the complete blood picture, routine repeat at the 28 weeks, liver function test including ALT, albumin, bilirubin, repeat 28 week of gestation, INR, hepatitis C, PCR. Again, you have to has been confirmed this pregnancy. Do not repeat the quantitative PCR if HCV RNA positive with unknown viral load or previous low positive viral load less than 1,000 copies per milliliter. A repeat PCR between 35 to 37. If you want this one, the this guideline, you can just hepatitis C SA health, type in the Google, then you can find it. Okay. And the intrapartum management, the risk of vertical transmission of hepatitis C virus appear to be related to the level of viremia that pregnant mother. There are no evidence that the C-section will reduce the risk of perinatal transmission. High yield topics I have shared in a group, doctor. There is a file in the group high yield topics. So my file is there, so you can have a look. Okay, you can have a look because those are repeated. I made that for 2025 exam, but I have not added the new topics that they have came in 2026. I will make a new file as well soon. Okay, because in 2026 they have given a lot of new topics. Okay, okay. Hepatitis B, I have not mentioned anything. Just I asked about the tenofovir, and I was telling that in the TG there was a clearly mention about hepatitis C. Sorry, hepatitis B. Hepatitis C, doctor, I just explained everything. So these are all okay. You can watch the recording later, okay? Because everything is I just explained, okay? Because I can't repeat it again. So you can find it this one in the essay health, and okay, you can watch the recording, okay? Because everything I just explained. Yeah. Okay, we were in interbody management. The risk of variable transmission of hepatitis C virus appear to be released to the level of viremia in the pregnant mother. There's no evidence of C-section. So some doctors are thinking if the hepatitis C present or active or like the patient is having antibodies, they are thinking the risk of transmission is reduced by C-section. So please remember one thing, the hepatitis C is not an indication for C-section. What is the point? Hepatitis C is not an indication for the C-section, right? It's not an indication. But there's a one question in e-medicine, and they have mentioned hepatitis C mom with prolonged bradycardia. Prolonged bradycardia for 7 minutes. Prolonged bradycardia for 7 minutes with the variable deceleration, as I remember, variable deceleration. In that case you need to go with c-section, but the problem not because of the hepatitis C, because of the fetal compromise, right? Because of the prolonged bradycardia. Okay, so don't confuse those things, because next day don't ask me, Dr. Sithara, there is a question in e-medicine, hepatitis C mom, then they have choose c-section. That is a different scenario. Okay, because hepatitis C alone is not an indication for the C-section. Keep this point in your mind. Okay. Okay, but you have to prevent. You have to prevent. You have to prevent these things. Fatal scalp electrol if the mom is hepatitis C. Fatal scalp blood sampling, vigorous aspiration or oral suction of the baby. These should be prevented. These should be prevented. Okay. Okay, here. Then at birth, standard precautions is enough. You don't need something like a specific, very specific things. You don't need, because there was another question, as I remember in e-medicine, that for hepatitis B mom, they are asking about the delivery and what are the precautions, and the answer, we have standard precautions and we have something beyond standard precautions. The answer should be standard precautions. Please do these questions. If you want, I can share the TG one in TG explanation for hepatitis B also in the group if you want. Like write in the our main group. Okay, I will share the files. Yeah. So standard precaution is enough, like protective eyewear, gown, apron, gloves should be worn by the doctor. The postpartum, if the woman is susceptible for hepatitis B, recommended combine hepatitis A and B vaccination to the woman. The woman is immune to hepatitis B, recommend hepatitis A vaccination to the woman. Care to the baby. The skin at the injection site should be cleaned with soap and water if visible blood, or with alcohol swab before administering hepatitis B vaccine, immunoglobulin, or vitamin K. The baby should remain in the birth room until transfer to the ward unless transfer to the nursery is indicated. Consider washing with soap and water any visible blood or bloody fluid from the hair on the skin before contact with the extended family. Okay, those are the main important things. Okay, main important things. I hope you got the idea. Right, we have covered a lot of topics. Yeah, doctors, now I think we can finish our session, right? We can finish our session. I haven't even take the break. So we have discussed a lot of topics, right? This doctor. Yeah, you can use this. Oh, yeah, you can use this book as well. This is a good one. Yeah, you can use this one as well. Yeah, that is a good one. Yeah, I have shared this book as well in the group. If you want, you can find it out. Okay. Okay, what question do you want me to ask the doctor? You can type in the chat. Yeah, no problem. What's the problem, Doctor? Doctor Ahmad? Yeah. Okay, you're asking high yield topic class for August students. Okay. Yeah. Okay, sure, doctor. High yield topic class. Mm-hmm. Okay, 2:32, and I'm having an exam in September. Okay, so yeah, you exam. Yeah, thank you so much. Other doctors, you can go if you want, because I'm going to answer some questions. I did exam last year in 2:37, and I'm having an exam in September. It is good. Exam so many new topics. Uh, no, doctor, we are on the July session, not over. Few like 4 days still left with us. So here, okay, doctor. November. Do you remember me? I think we all in the same classes. Yeah. Okay. Okay, Doctor Ahmad. Okay, okay. So, how is your preparation actually? First of all, I need to answer about your preparation level, because otherwise I can't directly tell you like this. Okay, if I have done like the theory part, but if theory part like in a with the proper guideline, like the TG and other related hospital guideline and the medicine and everything, if you have covered the theory part, and if you know like a exact theory point, and if you're doing recalls the way this way, like the do at least 6 months of recalls, because you have already done one time. That's what I'm telling. You can do at least 6 months of recalls a good way. Like, take the topic as example. If you get a hepatitis C question, just go through everything that they can like this. Do at least 6 months of recalls in this way, and you will cover all the syllabus. Like, you can cover like 95% of the syllabus. And at the same time, I'm telling you to do daily random emergency question. The count should be like 20 to 30 or 30 to 40. Daily do those random emergency question. Why I'm telling this? But don't select the topic. If you want like some specific topics or the weak topics, you can select as example the different topics: heart failure, MI, the hepatitis C, hepatitis B, or something like topics are going like in related way. You can choose a few topics, and then you can do recalls, because I'm telling to do this way at least 30 to 40 recalls per day to to understand how the exam pattern. I know you know the exam pattern, the way they are asking. Because if you choose the exact topic, and if you're doing the questions, you know they are asking from this topic, and you can easily answer the question. Because if you are doing that way, you can cover a lot of emergency question. By the same time, while you are doing the recall topic, sorry, not the recall topic, emergency question, try to understand why not other options. As example, if you get a question and you know the correct answer, and just give it a read, why not other answers are correct. That is the another most important thing. You can build up your theory and everything. Okay, you can build up your theory and everything. So if you ask in your plan, if you have already done like 6 months of records, is the proper way. Don't use AI. Okay, don't use AI. Like, just type the question. Most of doctors doing copy paste the question, and just take their answer, because AI is not giving the proper answer. If you can check in different AI the same question, they will give a different answers. Okay, that's what I'm telling. Because I know some doctors who have done the exam, and they most of the time they use this AI, and they have not passed the exam. Okay, you can use AI to like the write down summary or something like that. You can make some notes or anything. You can use to create the picture. You can use for that, but don't use AI for the answering. You need to find out the proof. Okay, because recently also in my July recall revision also, I showed the doctors, because we had some we had some conversation about the AI use, and I showed like we use different AIs, and the same question they have given different answers. Because exam week, all I have seen a lot of questions, and using most of them are those AI question. And please, in the exam week, just try to find the proper guideline and get the answer, because I am so sure what happened with you is during the exam week you most probably mark the answers, mark the exact answers during the exam week given, right? Because I know most of doctors, even with me, some doctors did the exam and they marked the answer that the given, the marked answer in the exam week, and they got failed, right? Right. So because of that, I'm telling, even in exam week, make your notes it very, very precisely, very clearly, and like try to understand the question, because like 237 mean it's like a near win. Okay, near win. Most probably you have left with some 5 or 6 questions, or like maybe less of amount, right? Maybe like that. Because of that, you need to be like, make sure you are following a proper guideline, because you can see AMC is always like a guideline based exam. But the thing, exam felt difference compared to emergency question. Like emergency give a lot of pros. Yeah, that is the other thing. The other thing was the exam date. Exam date. Yeah. The other thing is exam date. It's impossible to pass exam in. I can tell you it's impossible to pass exam in day one or day two. It's impossible. And day three, some doctors are managed to pass the exam. Day four also some doctors manage to pass exam. And if you really want to pass this exam, book your exam in day 5 or day 6. Okay, because at the end of the day 5 you are getting day 1 recalls, day 2 recalls, day 3, day 4 recalls, right? All you have a bunch of topic list. I'm not telling just follow the recall, I'm just telling you to follow the exact topic, right? Topic, because the topic is the one repeated, not the exact question. They are just changing the same stem with a one word. Sometimes there is example, okay, if they are giving a sweetie case. Okay, so day one we got the sweetie case, and so that one they are asking initial management. So Valsalva, okay, Valsalva. Then you mark the answer with with the recalls. Then in the you are doing exam in day 5. They are giving the same SVT question with the hypertension. With the patient is having the hypertension. Patient is unstable. In that case also, if you mark Valsalva, you are wrong, right? In that case, if you day one, if you find, if you understand the SVT topic, not the answer, how to manage, how it present, what is the ECG features, what are the symptoms, how ECG present, and what is the stable patient management, and what is the unstable patient management. Stable patient management, Valsalva. Then adenosine also, if the patient is asthmatic, you can't use adenosine. Then in that case, you have to use with verapamil, right? If those are not working, then we can think about the other options like metoprolol tartrate, right? Like that. If it is unstable cases, you are not going with those verapamil, adenosine, valsartan, you just need to use the DC cardioversion, like that. That is the way you should remember the theory part during the exam. And during the exam you have to read it. I'm so sure that what happened with the Dr. Hamad is that was day 2 and you have not getting the enough recalls, and during the exam you get uh, because like day 2 is always like a exam that we are getting a lot of question, because most of doctors have to do the exam in day 2. Why? Because they don't have later days, especially in the doctors who are doing exam in New Zealand. They only have the day 1 and day 2. So in that case, unfortunate can be happen, right? So because of that, like you have to make a plan, and once you, like, if you fail in one attempt, what you need to understand, it's so sad, right? Because the exam is expensive. At the same time exam is expensive, at the same time your time, your family time, right? Your dedication, your hard work, everything you feel like everything has gone away, right? Without having anything, right, for yourself, because you need to pass this exam to work as a doctor in Australia, right? So you will be very down. But at that time, I'm telling you, because sometimes that is not your time. Like, understand your mistakes. Maybe for the doctor that who asked the question, his mistake was what? His mistake was doing exam on day two, right? Then, because I'm sure most of doctors are listening who has failed one time the exam and listening this, make a paper and write down your mistake. The exam did you examine day two or day three or day four? That can be one mistake. The other mistake can be not haven't done enough e-medicine, not haven't done enough e-medicine. The other one, not have done past recalls, at least not 6 months recalls. The recalls has done in the wrong way, just question and answer, question and answer. That can be the other mistake. There can be a lot of mistakes. The other mistake can be the exam mistress. If you're doing in day two, the most the unfavorable thing is the exam mistress, because you are doing in day two and you only know the day one recalls. Day one recalls are not much repeating in day two, because day two is like the a lot of huge amount of recalls we are getting. Once you see those recalls, not okay, you are doing exam in day two and you are getting a new question, even though you have studied that topic multiple times. Once you see that topic, once you see that topic, you feel like you're panicking. Oh, I know this topic but I can't remember, because exam stress is not a good thing, because you have worked hard, you have you have write down those things, you have done multiple times that topic. Even though you saw the question, you feel like stress, then stress, and this stress reduce your thinking capacity and you're panicking and you have only 1 minute and you are stressing out and you can't mark down. You just mark something and you just move to the next question. But at the next question, okay, you are just thinking, oh my God, I know the proper answer, but I have marked it wrong. So you can't change the past, right? You are thinking about the previous question at the same time. This question, and that is stress come to the second question. You are continuing this question, this stress throughout your exam. It's very hard to pass the exam, right? That's why I'm telling doing in the later days better, because if you're doing in the day five and most of topics are repeated. I'm not telling the AMC is not a fool. Okay, Medical Council of Australia is not a foolish thing. Okay, they are not repeating exact same question, but the topics are repeated. If you have done the topics in properly during the exam, we can use the exact topic in the topic. Okay, I'm not telling the question. As example, pneumothorax you have done in day two and you have gone through the theory and everything. Okay, day five you see pneumothorax, so you feel like you feel so confident. No, I have done this in exam weekend. Okay, I know everything that they can ask. I know the key points. That confidence help reduce your anxiety and that help you to answer correctly. That help you to answer correctly. Okay, that's what I'm telling, the importance of the later days. Okay, that is the important. So I don't know if you are, because I am telling this from my experience, okay, from my heart I am telling, because I also recently did my exam in November, so I'm very familiar with this system, okay, system, because I recently done, because when I was doing the e-medicine came, right, so I'm very familiar with those things, in the materials and everything, and I'm telling everything from my experience, okay. So what are the does day three has repeated from day one and day two? Day three also, doctor, a lot of new questions are coming. Even day four also a lot of questions are coming. But I can't tell, like, day three also manageable. Bit depend on doctor, because your luck also matters. Okay, your luck also matters, because this is AMC, right? Your luck also matters. Yeah, but don't take a risk, doctors. If you have enough money to rebook the exam, and if you have a strong mind to do it again, then do exam in day two or day three. But otherwise don't do it. Okay, if you are rich enough to book the exam, and if your mind is very tolerable to do this same thing again and again, do it on day one or day two or day three. I'm telling that. Okay, otherwise don't do it. Advice for doctors having in August exam on Wednesday. Okay, Wednesday. So now you can't change it, right? But you can do. Please, doctor, go through the July, those the February, March, this exam, this year exam records, because I have seen in these past few years a lot of question repeated on these Feb, not actually Feb, March, April, May, and this June. Even in June, July also, day 3 and day 4, those times also, those like most of those questions have repeated. But if you have done those things properly, you can still manage the exam, okay? Because don't be discouraged. I just saw your message. Don't be discouraged. You already have a book. Try to do those recalls very good way, like those topics. Make the list of those topics from March, April, May, and June, and the July. So you have 6 months of recalls. Recall topics. Make sure you know every single point for each topic. So that can help you to pass this exam in day 3. Even though you are getting, I know you are getting you are getting recalls, but day 3 it's like new topics are coming. Okay, that's what I'm telling. Make sure you have followed those 6 months of recalls topics very good. You are very good at it. Then those topics are the new topics that come in on day 3. Okay, so now it's, don't worry, you can do it. Okay, don't be discouraged, you can do it because you already have done 6 months of recall. That is more than enough. But don't panic, because to reduce the panicking, I'm telling you to do the exam in the later days. Okay, but if you can control your mind, you can do it. Still, you can do it. Okay. Yeah, I think yeah, you have got a great idea. Can we get your theory short notes? TG, I have shared all of my notes that I have used during my preparation in my group. Doctor, you can find it in the theory in my file section. Yeah. Video. Okay. After the session, usually this will take like around 30 minutes to convert from Zoom to my device. After that, I will upload in the YouTube. I should hire an assistant because I don't have time to generate picture for the YouTube thumbnail, right? Someone should help me. Then I can do it easily. Even I have a lot of videos in the draft section in my YouTube channel, because I was not able to generate pictures for different topics. Otherwise, I can't upload, like it's ugly, right? Like you need like something attractive and catchy to watch the video, right? Okay, thank you so much, doctor. Actually, I need help from someone who like to help me. Okay. Thank you so much, doctors. We'll meet tomorrow as well, okay? Tomorrow as well, I will help you. What do you prefer? Do you want the recall sessions or theory sessions? I will consider that one. Okay, focus doctors higher topics. What about other than that? What do you prefer? The recalls or okay recalls? What about other doctors? Because my recalls is like anyway you are covering the theory, right? It's like a theory plus recalls. Okay. Okay, so we'll do. Okay, start. Okay, start. Okay, doctor. So we'll meet tomorrow. I will upload the time, rapid revision, and the especially the August doctors. I have done a lot of rapid revision, lot of rapid revision. I think 6 or 7 videos in my YouTube channel. Please go through each and every video that I have uploaded, because I have done a lot of rapid revision topics. Please go through those things, because that covers like around half of the syllabus. Okay. Okay, okay. Go through. Please don't forget to like go to the YouTube channel, because early I have uploaded a lot of videos. Okay. Okay, okay, doctors. And I have uploaded a quick revision for the images, imaging, and everything as well, and the dermatology pictures. And I have done a lot of sessions, especially for the exam week doctors, the exam coming doctors for April, and I have done April, March, and May also. Can't remember, but go through the YouTube channel, the playlist, and you can find it out. Yeah, at the same time, you can like, subscribe, and share, right? Okay, okay. Thank you so much, doctors. We'll meet tomorrow. Okay, have a good day. Bye bye.